for today.
Hi, everyone. My name is Iktimal. I'm a third-year resident for those who don't know me. Today, I will be talking about gastrointestinal bleeding, and the main focus of our lecture will be upper GI bleeding. Last two slides will be a bit about lower GI bleed. I'm going to start with a case presentation, but we are going to talk about it later during the presentation. So we have here a 60-year-old female with a past medical history of hypertension, alcohol use disorder, who presents to the ED via EMS. She was feeling nauseated. She had one episode of vomiting and reported some fresh blood with the vomit. She has a prior history of hematemesis, but no EGD before, no colonoscopy. She's really asymptomatic except for... Hello? Hello? She's asymptomatic except for vomiting, and she does not use aspirin or ibuprofen. Why is GI bleeding important? First, it's one of the most common causes of hospitalization. Over 500,000 annually of admissions in the United States are related to GI bleeding. Mortality is high. It's between 2 to 10%. And of course, people who have comorbidities, who are older, will have worse outcomes. And if we miss it, it can be fatal. We're going to start with some anatomy, upper versus lower GI bleeding. So we have the ligament of Treitz. It is a double fold of peritoneum connecting really the duodenojejunal flexure to the diaphragm. So anything proximal to it is considered upper GI bleeding, and anything distal to it is considered lower GI bleeding. So upper GI bleeding is really esophagus, stomach, duodenum. Lower GI bleeding is more so colon, rectum, anus. And anything in between is considered small bowel bleed. We're not going to talk about it. It's out of the scope of this talk. Okay, who can tell me how does upper GI bleeding present? Okay. Melena. Hematemesis, right, like this case. And there is also one less common presentation. It usually comes with lower GI bleed, but it can definitely also present with upper GI bleeding. Hematochezia, right. If the patient is really significantly bleeding and hemodynamically unstable, upper GI bleeding can present with hematochezia, less common though. So we can see some pictures. Hematemesis is really fresh blood. Coffee ground emesis is darker, and it's due to the acidity of the stomach. Melena is tarry black stools, and it has a very, very strong odor. You're gonna like smell it in all the floor when you have a case of melena. And finally, hematochezia is just fresh blood from the stools. We're going to discuss causes of upper GI bleed. Who can tell what are the most common causes of upper GI bleeding? Ulcers, right? Peptic ulcer constitutes like 50% of upper GI bleeding. What else? Varices, second most common. Cancer. Good. So those are the most common, really. We have less common causes that we're gonna talk about, but it's rare to see them in the hospital. So common causes of upper GI bleed, we're gonna start with peptic ulcer disease. We have two most common causes, right? NSAIDs and H. pylori. And usually the treatment would be PPIs and EGD. For varices, what clinical clues we need clinically to really think about varices? Jaundice. No, good. Like what? Okay, good. Also, if a patient is drinking a lot of alcohol, even if she doesn't have a reported history of cirrhosis, we still treat variceal bleeding unless proven otherwise. Mallory-West, what do we need to ask about, to think about Mallory-West? Vomiting or retching? Good. Erosive esophagitis, it is one of the causes of upper GI bleed, but really, if it is significant upper GI bleed, we need to investigate for other causes. It wouldn't cause significant bleeding. Malignancy, less common causes. Really, the most important cause here is aortoenteric fistula. because it's one of the most fatal causes of upper GI bleed. What do we need to ask in every single case of upper GI bleed to rule out, or not to rule out, but to really think about aortoenteric fistula? It's really a fistula between the aorta and the colon. Mm-hmm. Mm-hmm. We ask about any aortic aneurysm repair, any aortic grafts. Those are the people that can develop aortoenteric fistula. Also, if someone has, for example, a recent liver biopsy, trauma, we need to think about hemophilia because it will cause some GI bleeding in the hepatobiliary tree. So mechanical Cameron erosions, those are erosions that happens with hiatal hernia, because hiatal hernia will cause some mechanical trauma to the stomach. And it also presents with iron deficiency anemia. We have some vascular causes, Dulafoy and gastric antral vascular ectasia. Does anyone know the difference between those two entities? Okay. Dulafoy is really a big artery that's very tortuous and very aberrant, and it erodes the gastric wall and it causes significant bleeding. Gastric antral vascular ectasia is more so chronic dilated veins, not artery, and it can cause chronic anemia and chronic bleeding. There is a particular characteristic shape of the stomach with gastric antral vascular ectasia. Does anyone know how it looks like? It's called watermelon stomach, because if you, I should have put a picture there, but it really looks like a watermelon. Fistula, we spoke about aortoenteric fistula, duct bleeding like hemophilia, we discussed it, and hemosulcus pancreaticus. This entity, you're gonna suspect it if you have a pancreatic pseudocyst or a pancreatic tumor that is eroding the pancreatic vessel, and the pancreatic vessel will bleed into the pancreatic duct. Portal hypertension, cirrhosis, and finally, GI tumors could be benign, could be malignant. Approach to upper GI bleeding. So when we are at bedside, very important, we need to recognize bleeding pattern, as we discussed earlier. Is it hematemesis? Is it melena? Is it hematochezia? We need to check the airway, the vital signs. First thing to do in the management is really to resuscitate the patient, and then we can do further management that we're gonna discuss later, and of course, send labs. We have two parts in the management. We have before endoscopy and we have after endoscopy. First step before endoscopy is to stratify how severe is the case. We're gonna think, is it variceal bleeding versus non-variceal bleeding, because management differs a lot between those two. And we're gonna consult GI. Of course, we're gonna call them, especially if the patient is actively bleeding, we're not gonna wait. After EGD, we need to discuss what is the PPI plan long-term, what is the diet plan after endoscopy, if the patient has rebleeding, what we're going to do, and how are we going to prevent recurrence, especially in variceal bleeding. History taking, what we're going to ask for history taking. Good, because you're thinking peptic ulcer, right? Uh-huh. Mm-hmm. Aortic surgery, right? That's one of the most important things. NSAIDs, history of H. pylori, prior history of GI bleeding, prior EGD or colonoscopy. Is the patient having syncope, dizziness? Is the patient on anticoagulants? That's very important, because some cases of anticoagulation we need to reverse. We're going to discuss later when to reverse, but we need to know if the patient is on Eliquis, if the patient is on warfarin, if the patient is on dual antiplatelet therapy. Okay, vital signs. So high-risk really clinical findings are hypotension, tachycardia, syncope, ongoing hematemesis, patient actively bleeding in front of your eyes, altered mental status. Which vital sign will be the first one to change in GI bleeding? Heart rate, right, tachycardia. And then we need to think really about the disposition. If the patient's having shock, hemodynamically unstable, we need to emergently intubate them. They're going to ICU. There is a score that I'm going to talk about in a later slide, and that really helps to decide whether we're going to do inpatient management versus outpatient management, and anything in between is going to go on the floor. Any person who's really stable, not actively bleeding, and hemodynamically stable, not altered, do not need intubation or vasopressors. Physical examination, we discussed what are the stigmata. What's your name? Sorry. Now, Hamza already told us like we need to check scleral icterus, ascites, spider angiomas, palmar erythema, abdominal tenderness, peritonitis, because we might think SBP, right? And DRE. DRE really is more important in lower GI bleeding than upper GI bleeding, but usually in any case of GI bleeding, if the patient is stable, needs DRE for sure. And mental status. Why do we need to know what is the mental status and if the patient is encephalopathic? Right, because we need to emergently intubate, right? If the patient is not protecting their airways. So what kind of labs do we need to send for upper GI bleeding? CBC, right, type and cross, CMP, which includes the liver function test. Anything else? Coagulation panel, lactic acid, right? Okay. Who can tell me what are the liver function tests? Daniela, INR. What else? Albumin and bilirubin. So remember, liver enzymes are not part of the liver function test. Function test, you're assessing the synthetic function of the liver and other functions of the liver. So you're going to see high INR, you're going to see high bilirubin, you're going to see low albumin and liver failure. Those are the function tests. And whenever we're seeing those changes that are really pointing towards cirrhosis, this is when we think maybe varicose bleeding. So we discussed the labs and how frequently do we need to trend hemoglobin? So it really depends, right? How stable the patient is. It's anywhere from Q2 to Q12. Usually Q2 to Q4, that patient probably is in ICU. Q8 to Q12, if the patient is not hemodynamically unstable and not actively bleeding, and anything else is Q4 to Q6 hours. Usually on the floor, we do Q6 or Q8 hours when the patient is coming straight forward from the ED. Of course, we need to trend vital signs. The patient needs to be on telemetry. We're going to talk about transfusion thresholds in another slide. We need to monitor urine output to make sure the patient is not in shock and having renal failure. Of course, mental status. And what do you think? Do we really need imaging in upper GI bleeding? Or let me phrase it this way. When do we order imaging in upper GI bleeding? Sorry, I didn't hear you. Oh, ulcer perforation. Okay. Yes. So that's the thing. If we don't have a source, let's say the patient had an EGD and we really don't have a source. If the patient has another indication like acute abdomen, and anyway you need a CT, but otherwise you don't need imaging for upper GI bleeding unless we really don't know what's going on or we have another indication for CT. You're gonna see it a lot in the ED. Everyone with bleeding and abdominal pain are gonna get a CT scan, but it's not the standard of care. EGD really is the way to diagnose and treat at the same time, right? Mm-hmm. Looking for air from that. But when else do you might need a check? If they're encephalopathic, what do you think might happen? They might have like a aspiration mode node instead of ceftriaxone if you're gonna dose in or something with anaerobic. If we have a patient with normal hemoglobin, are we happy? Are we not happy? Are we comfortable with it? Good, very good, Hamza. So normal hemoglobin doesn't really indicate anything because the patient could be actively bleeding, and in acute bleeding, the hemoglobin didn't drop, or they could be also hemoconcentrated. So the normal hemoglobin doesn't mean the patient is not actively bleeding or is not gonna decompensate. Of course, high BU and creatinine ratio also points toward upper GI bleeding, and INR itself, it's a good indicator of liver function, right? Because the patient could be in liver failure, could be cirrhotic, but it doesn't mean high INR means automatically that the patient has high risk of bleeding. Some people have high INR and not bleeding. Management first 10 minutes in ED, usually ABCs, airway, breathing, circulation, assess if the patient needs intubation or not, 2 large bore IV, usually 18 gauge, telemetry, vital signs, put the patient NPO, nothing per mouth, type and screen, cross match, and give IV fluids. This is the first step for any upper GI bleed, is really resuscitation with IV fluids. And we're going to call GI. Usually ED will call GI before we get the patient on the floor. When do we intubate? Already Dr. Kazelka said, right? Acute encephalopathy, patient not protecting their airway. If the patient is really significantly vomiting blood, then you're not going to wait. You're going to emergently intubate, high risk of aspiration. Okay. Transfusion threshold. What is our goal hemoglobin for upper GI bleeding? 7. Okay. Do we have exceptions where we're aiming for higher thresholds? Good. Severe cardiovascular disease, we're aiming for 8, right? Okay. What if the patient has acute cardiac ischemia? We need to aim for higher. So acute cardiac ischemia, we're aiming for 9 and 10. Severe cardiac disease, like coronary artery disease, we aim for 8, but any other patient, we need 7. But let's say I have a patient and I know is getting hypotensive, hemodynamically unstable, 7.5. Am I going to wait for the hemoglobin to drop less than 7? No, we're just going to go ahead and transfuse. Okay. Just to be cautious, when we know that the patient has varices and they have variceal bleeding, we need to avoid overtransfusion, because when you're giving a lot of transfusion, the portal pressure will rise and we're going to have high risk of free bleeding. And also, when do we transfuse platelets? What is the threshold for upper GI bleed? 50,000. This is the score I was mentioning earlier. It's called Glasgow Blatchford Score, GBS. You can find it all on MD-Calc, and you can log the information of the patient, including BUN, hemoglobin, systolic blood pressure, heart rate, melena, syncope, hepatic disease, cardiac failure. And then if the risk is 0 to 1, then you can really discharge the patient and manage outpatient. But this score shouldn't replace clinical judgment, because if the patient is actively bleeding, or if you feel like the patient is not adequate for outpatient management, then don't send her home. But this score really helps stratify. Anything above 1 is inpatient. Okay. We discussed really variceal versus non-variceal, and how what clues in the history and the physical exam point toward both. Pre-endoscopy, okay, we need to start management now, and we know that it's upper GI bleeding. We're not quite sure yet if it's variceal versus non-variceal. What is the first step in management? NPO, good. Endoscopy, or do we need to stabilize first? Right, okay, so IV fluids, right? What else? Good. IV PPI, right? We can discuss about PPI, but who wants to give? If you're suspecting variceal bleeding, we need to start octreotide drip, and we need to start prophylactic antibiotics, ceftriaxone, right? We can discuss that further, but very good thoughts. PPIs, are we gonna do pantoprazole 40 IV BID? Are we going to do a pantoprazole drip? Loading dose, okay. And then? Okay, who wants to do drip? Both of them have the same effect, really. It all depends on the logistics, availability, cost, and GI preference. So there's nothing wrong. I know sometimes we're upset, like, hey, why GI said we need a drip? It's all up to GI preference, but there's nothing wrong in both approach. But of course, like IV40 BID is easier for the nurse to administer. It's less cost for the hospital, and same effect anyway. Okay. Who wants to order an FOBT? No role for FOBT, right? Especially if we know that the patient is GI bleeding, what is gonna tell us? Okay. What is the dose of ralsafin we need? It's usually 1 gram. We're talking now variceal bleeding, right? So variceal bleeding, we need prophylactic antibiotics. Why is that? Because it's been shown that a big percentage of people who are cirrhotic and have variceal bleeding have high risk of infection, like pneumonia, urinary tract infection, SBP. So we need to give empiric antibiotics. For how long? What's the course of ceftriaxone we need to give? Usually it's 5 to 7 days. And let's say we're discharging the patient earlier because the patient is stable, completed EGD, we can send them on a short course of ciprofloxacin to complete 5 to 7 days. There are some emergent, like recent studies that are comparing how about we do like 3 days instead of 5 to 7. It didn't show much difference, but the guidelines until now are 5 to 7 days antibiotic course for varicose bleeding. Octreotide drip, it's usually a bolus of 50 and then a drip, continuous drip. Octreotide really works. It's a somatostatin analog. It constricts the blood vessel. It decreases the blood flow, the strengthening blood flow, and it decreases the portal pressure. That's why it decreases the risk of bleeding. IV PPI, we discussed we can do either a drip, either intermittent, and then we consult GI. And if needed, usually varicose bleeding are very severe, and usually they want in the ICU. Okay. For how long are we giving this high dose PPI? Like 40 IV BID or even more. Sometimes they do 2 or 4 times a day, and sometimes we do the drip. For how long? So the answer for this is it really depends on the endoscopy findings. Each GI has a certain criteria to decide whether the ulcer is high risk or low risk. Let's say the ulcer, we didn't find any stigmata of bleeding, that's a low risk. But if we find like a high stigmata of bleeding, this is a high risk. So if the GI comments in the endoscopy, this is actively bleeding, this is a high-risk ulcer, then we need to keep this big dose for 72 hours, 3 days. But if it's a low risk, we don't even need to do PPI, BID. We only do 40 once daily, and we can discharge the patient. High risk, 3 days, IV, PPI, 40 BID, or a drip, and then we transition after 72 hours to oral 40 BID for 2 weeks, and then we can do once daily. So really, if it's high risk, they need to stay in the hospital for the IV dose for 3 days. Okay. All right. So if the patient has ulcer, they take biopsy from the EGD and they send it for H. pylori testing. Let's say, this is just a clue here, but I didn't mention it here. If the biopsy results are negative for H. pylori, are those really reliable, or are we going to repeat the H. pylori test later on, and why? Good, really good. So we have a big percentage of false negatives initially because the patient is actively bleeding and there is a lot of acidity in the stomach. So this is why they're not very reliable, the initial biopsies. And then we can repeat on an outpatient basis when the patient is not bleeding anymore. We can do a breath test or stool studies. Okay. Anticoagulants or antiplatelets. Who can tell me when do we need to reverse anticoagulation? If the patient is on warfarin or Eliquis, when do we need to really reverse? Is that every patient with upper GI bleed? It could, but it's mostly in life-threatening bleeding. If the patient is hemodynamically unstable, shock, ICU, this is when we need to reverse. Okay. If a patient was on aspirin and it was for primary prevention, like he doesn't have a stent, doesn't have coronary artery disease, we need to completely stop it. We don't need to resume it. If the patient is taking it for secondary prevention, this is when we need to think about when to resume it, and we need to discuss with both GI and cardiology. But eventually, we need to aim for within 5 days to resume if the patient is hemodynamically stable and not bleeding anymore. If the patient had a recent stent, also it needs to be a conversation between cardio and GI. If the patient is on dual antiplatelet therapy, sometimes we need to give up on one of them and continue with aspirin or Plavix and not both together because the patient was actively bleeding on both. And of course, if the patient is on warfarin or Eliquis, it all depends what is the indication. If the patient has AFib, for example, we need to calculate the Shasva score. If it's high, then we need to resume sooner than later. If the patient has mechanical valve, also we need to resume earlier. The aim really is usually within 7 days, and we need to have a clear plan from GI, and we need to document it, especially like interns. We need to document when are we planning to resume Eliquis or warfarin or antiplatelets. Now we're going to discuss EGD timing. So if the patient doesn't have, we're not suspecting variceal bleed, when is a good timing for EGD? Do we need to aim for within 6 hours, within 12 hours, within 24 hours? 24 hours. Old guidelines were pointing toward doing it very emergently, within 6 hours, but it has shown actually higher mortality when you do it soon and you didn't stabilize the patient enough. So usually within 24 hours is a good timing. But if the patient, of course, is hemodynamically unstable, despite resuscitation, if the patient has variceal, suspecting variceal bleeding, then we do it sooner. We do it within 12 hours. This is really out of the scope of this conversation. I'm going to just go over it very quickly, but there are a lot of options during endoscopy to stabilize the patient. If the patient has an ulcer, for example, they can clip it, they can apply thermal therapy, they can do some epinephrine injection, and they can do some hemostatic powder. For varices, it really depends. Is it esophageal or is it gastric? Usually esophageal varices, the treatment for it is really to bend it. Gastric, it really depends on the size and on the location. Some of them are amenable to bending, some of them are not. And this is when we do TIPS, which is transjugular intrahepatic portosystemic shunt. It's really a shunt between portal system and the hepatic system, and it decreases the portal pressure. And this is how they decrease the bleeding. They can do some type of glue, which is the cyanoacrylate. They can coil it. If the patient is really hemodynamically unstable, and we're not going to wait for the EGD, if the patient is having variceal bleeding, we can do first balloon tamponade, and then they can do EGD later when the patient is more hemodynamically stable. Post-endoscopy care. We're done now with the EGD. We're going to discuss what is the plan in terms of PPI, in terms of diet, in terms of anticoagulation, when we're going to resume it. And finally, we need to prevent recurrence. So what are we going to use to prevent recurrence of variceal bleeding? Good, that's the first, first answer. What else? Which medication? Beta blockers, good. Non-selective beta blockers. Which one is preferred? Carvedilol, but we can also do propranolol and other non-selective beta blockers. What is the aim? What is the goal heart rate in upper GI bleed? It's 55 to 60 usually, the heart rate. And when are we going to start beta blockers? I have a patient now done with endoscopy, found to have varices. When I'm going to start the beta blockers? Usually after I stop the vasoactive therapy, like after stopping octreotide. Usually octreotide, you keep it between 2 to 5 days, depending on each case. Usually we do it 3 days in the hospital. After stopping the vasoactive therapy, this is a good timing to start beta blockers. Okay, PPI. High risk ulcer. For how long are we going to give the high dose PPI? 72 hours. And then PO, pantoprazole, 40 BID for 2 weeks, and then we can do it regularly once daily. If the patient has low risk, what do? We do it only once daily, and when they don't have to take it IV, they can go home. Okay. An antibiotic course, Rocephin, 5 to 7 days. Okay. All right, rebleeding. The patient already had an endoscopy, patient's completely stable, hemoglobin is stable, still having melena. What are our thoughts here? So it was a tricky question here. If the patient is hemodynamically stable and hemoglobin is stable, and you're not suspecting that the patient is actively bleeding, melena takes a couple of days to clear. So it's very expected to see melena for the first couple of days. We don't have to freak out and call GI. But if the patient is still having hematemesis, still having melena, but the hemoglobin is actively dropping on hemoglobin trend, or if the patient is running hypotensive, that means that it's either the wrong source, either the source was not clearly targeted. This is when we do a repeat endoscopy. And then if they still couldn't manage it with repeat endoscopy, this is when we need IR for embolization. And we can do CT angiography and further workup. Going back to our case, now we know that it was variceal bleeding. We went over the management, so I'm not going to go too deep in this case. And I'm going to start talking about the order set. Is it HIPAA violation if we project the patient the weekend? Okay. And even with Wesley Chapel on the fine. Okay.
By the way, they had a question.
Oh, yeah. Can you please comment on the sensitivity of fecal H. pylori testing while on PPI therapy, or if PPIs must be held prior to retesting, and how to manage this in patients with risk of recent bleeding? So really, this is a different. Oh, sorry. Yeah. So the question is, can you please comment on the sensitivity of fecal H. pylori testing while on PPI therapy, or if PPIs must be held prior to retesting, and how to manage this in patients with risk of recent bleed? This is a really good question. Usually PPI affect the sensitivity of the H. pylori testing, and yes, it needs to be held prior to the testing. But our main concern here was in biopsy. Biopsy is not accurate in active bleeding. If the patient is not actively bleeding, we're doing a routine endoscopy, and then we're doing a biopsy. Well, this is accurate. But if the patient is actively bleeding, the biopsy results are not accurate. We're going to wait until the patient is hemodynamically stable, outpatient, completed PPI therapy, and then we hold it. Of course, GI needs to discuss the timing, when it is safe to do so, and we need to repeat the testing. Let me open the Epic chat.
I just kind of like looked that up real quick. It's saying that I'm just using. It's saying that for rapid urease testing, the sensitivity exceeds 90% for active infection, but drops to
75.
If they are on PPI or antibiotics, and acute GI bleeding. The sensitivity of the rapid urease testing unless it lasts more than a month.
You can also do serological tests in that case if you cannot stop PPI or if you cannot switch them to H2 blocker.
Right, but some of the tests, like even if you had an old H. pylori, they will still remain positive.
No, but
Right, but
The-
you're actively treating it and you're checking for eradication. So
Uh-huh.
that serology will show whether it's now
Yes.
or not.
Right,
so
right.
If you cannot stop, that would
If you
be
cannot stop the PPI.
because if it's negative, then regardless, H12 is
Advanced.
out of question.
An actual chart.
Yes, that was my question. It's fine, or
I don't know if you'll be able to see either.
because I'm sharing it?
You're on Epic trying to do it.
Mm.
I think she
Okay.
might be- We have
That
time.
might
So
the mic.
Okay.
as long as one of the outcomes were good. There is a-
Like the mic.
So we're gonna go to this patient. We have an order set in Epic for upper GI bleeding. I would really recommend everyone to use it because it has all the important steps. It's called upper GI bleed. Okay, so first we have NPO, of course, we have aspiration precautions, we have vital signs. And then here the nurse, with this checking notify provider, the nurse is going to talk to you every time she can see another episode of hematemesis or melena. We're going to check the hemoglobin, Q6 hours, and then we're going to check CBC, CMP, coagulation panel, INR, PTT, and then we have also IV fluids continuous. And then here we can check each one. If we're suspecting varicose bleeding, we're going to do Rocephin 1 gram, and we're going to check it. I'm going to suppose like this is a varicose bleeding case. So Rocephin first. And then the second step would be octreotide, right? So we can go to the drips, gastrointestinal, and this is the octreotide. It has the bolus and it has the continuous drip, 50, and then the drip. And then PPIs, usually I do 40 BID unless the really GI recommended otherwise. We're gonna also put the PPI in there. Okay, beta blockers not now, right? Because the patient is actively bleeding and we're doing octreotide. So beta blockers, we can consider them at a later time. What about DVT prophylaxis? We're not gonna do chemical DVT prophylaxis for sure, right? Okay. So this is the order set. Any questions about this order set? It's very clear. Okay. All right. This is just briefly lower GI bleeding. So what is the one of the most common cause of lower GI bleed? Diverticular bleeding, colonic ischemia, angiodysplasia, hemorrhoids. Usually hemorrhoids wouldn't cause hemodynamically unstable patients and very significant bleeding. Though I had one patient in the floor, and the patient really had needed transfusions and was unstable, but usually you really need to keep in mind that there might be another cause. Cancer, colitis, and we're gonna see mostly hematochezia. Imaging and lower GI bleeding are indicated. Upper GI bleeding, not much unless we have a specific indication, but lower GI bleeding, we need to do a CT angio, and then if there is active extravasation, we need to consult IR for embolization. And of course, if we're suspecting upper GI bleeding in hemodynamically unstable patient, we need to call GI for endoscopy. And then eventually in lower GI bleeding, the plan really is to do colonoscopy within, not necessarily like within 24 hours. We can take our time if the patient is stable, because we need a good view, right? Takeaway points. So always stabilize before endoscopy. If the score on the GBS score is 0 to 1, and if the patient is doing really great, we can always do outpatient management. Threshold for transfusion for almost everyone is 7, unless the patient has severe cardiovascular disease or active cardiac ischemia. Variceal bleeding main management is PPI, octreotide, Rocephin, and then EGD. EGD is usually within 24 hours for all causes of upper GI bleeding, except variceal bleeding, that we need to do it sooner, within 12 hours. PPI regimen, if it's a high-risk ulcer, we do high dose for 72 hours IV in the hospital, and then we do pantoprazole 40 BID for 2 weeks, and then we can eventually wean to one time daily. If it's low-risk ulcer, then we only do pantoprazole 40 daily. Of course, if the patient is rebleeding, then we need to repeat EGD first. If that fails, we can always consult IR for embolization. And finally, we always need to document what's our plan in terms of resumption of antiplatelets and anticoagulation. And for this hospital, we have 2 groups of GI. We have Dr. Sobia Ali, she's an independent provider, and we have the other group. The other group is pretty much all other GI. Dr. Hala Al-Jibouri, Dr. Al-Saleh, Dr. Adnan Muhammad, Dr. Patel, and the advanced GI are also with them. Any questions? Oh, Dr. Sabrina also. So Sobia Ali is one, and all other GI are in another group. Yes.
What is the role of terlipressin?
Technically, you could do octreotide, you could do terlipressin, you could also do, what's the third one? Yes. But usually in the hospital, I think the most common one that we find in the hospital is octreotide. Terlipressin, we usually use it for other hepatorenal syndrome. That's the most common indication, but you could, if that's the question. I think we're done. Thank you. Okay. Anyone in Wesley Chapel has any questions?
Thank you.
Thank you.
That was great. So much.
Thank you. Have a good day. Bye.
Just have one, very good, very fast. I just had just one thing. I looked it up actually. Dr. Sanders and I were reading it. That the active bleeding does drop the sensitivity of the rapid urease test in H. pylori from 90 to 75%. But the active bleeding does not affect the histology findings. You know, those little spiral little Helicobacter pylori. So when they take the biopsy, active bleeding doesn't affect us actually seeing the organisms, the histology, right? So the biopsy would still be close to 100% sensitive.
Thank you.
And then you always have to hold the PPI for 2 weeks before you recheck, before you redo a rapid urease test or a stool antigen, right?
Thank you. Oh, yeah.
Just out of curiosity, let's say you have a patient who has IBD and they maybe are immunosuppressed. Do you change what antibiotics that you give them?
So usually Rocephin has a good coverage of gram-negative endemic organisms, but of course, if you are having an immunosuppressed patient, you can always do broader. You can do Zosyn, you can do cefepime, you can always broaden it. Rocephin is like works in, it's one of the preferred antibiotics, but if you have another indication, then you always broaden your antibiotics. Because the point of the prophylactic antibiotics in peritoneal bleed is that over 20% of people who have variceal bleeding have bacterial infections. Could be SBP, could be pneumonia, could be whatever. Second is that antibiotics were proven to show decreased mortality, decreased rebleeding risk in variceal bleeding. So yes, you do broaden the antibiotics.
So you want to cover Pseudomonas if they if you're thinking that they have DRE, of course, the cephalosporins do not provide it. So you'll want to do something like
Carbapenem.
ampicillin. Not DRE one, or imitanum, if you're
Yes.
thinking DRE, something else.
And-
Ranitidine.
Yeah, and then if you have if you have a history of ESBL, you always do carbapenem. So
Question about strategy for so if the patient alertary and able to participate risk, but spectacles after GI bleed, we send the patient for on their way or not intubated.
no, if the patient is high risk and actively vomiting blood, then they need to intubate before doing EGD. So protecting airway is a thing, but also if the patient is actively in front of you, vomiting blood a lot, he's very high risk of aspiration. So we need to intubate prior to doing EGD.
Yeah, like frequent episode of bloody vomit in ICU.
Yes.
When
Yes.
not going to
Yes, we need to first stabilize, intubate, resuscitation, start the PPI, start the Rosifin, octreotide, everything, and then you do the EGD within 12 hours. Right, thank you.
You understood everything, or?
I'm not sure. You need to ask.
Very figure it out.
very nice.
Very ridiculous.